Hi all of you, we are going to discuss INICET PG Surgery Recall 2025. To me, the question appears to be easy to moderate and it is not very difficult, and the questions are come from the known areas and defined areas where surgery questions could be asked. And my experience of training more than 3.5 lakh doctors for PG entrance examination and also for 35,000 super specialty aspirants for DM and MCH exam, this question paper is a very standard paper and an easy paper and can attempt all the questions in surgery. I have collected few of the questions from the students I am going to discuss with you today. Okay, let us get started. What is izzatplasty used for? Izzatplasty is used for, and it is classically used for the scar revision and contracture release. It's one of the standard entrance exam question, and you can see if there's a scar, and then you can modify the scar and you can minimize the scarring, and also it's cosmetically important to do this. So in exam they ask you izzatplasty, it is for scar correction. And they can also ask you Abbey-Eslander flap. This is a very standard entrance exam question. Eslander flap. Abbey-Eslander flap is used for lip reconstruction. So one question that can be asked, and they can also ask you what is the flap that is used for? What is the flap that is used for the sacrum? That means pressure sore of sacrum. It's a rotation flap. Understand this. Rotation flap for the sacral pressure sores. Okay? Yes. Second question. A patient presents with a history of peptic ulcer and an image shows sleeve gastrectomy. What is the surgical procedure used for? I don't know what was the image that was given. If suppose the word sleeve gastrectomy is used, yes, and the right answer is this is a part of a bariatric surgery. The history of peptic ulcer disease, I don't know what is the correlation here. The bariatric surgery is a weight reduction surgery that is done, and sleeve gastrectomy is one such procedure. And in bariatric surgery with respect to entrance exam, they can ask you that maximum weight loss, okay, maximum weight loss is achieved in which bariatric surgery? The answer is BPD, biliary pancreatic diversion or duodenal switch procedure. One more question they can ask you, least weight reduction is achieved through which bariatric surgery? Yes, least weight loss, VBG, vertical banded gastroplasty. So this is a standard entrance exam question, and sleeve gastrectomy is a type of bariatric surgery. Bariatric surgery is a weight reduction surgery. Patients who have increased BMI. Which of the imaging modalities should be avoided in pregnancy? So the radiation should be avoided. I mean, X-ray also to be taken only if it is necessary and needed. And especially if you look into the options here of CT, MRI or Doppler and ultrasound. Yes, the right answer will be CT. The most preferable would be ultrasound, because most of the patients who comes with a RIF pain and most probably could be because of an acute appendicitis in pregnancy. Okay, an acute appendicitis in pregnancy, and the best could be an ultrasound, or ovarian disease, ovarian pathology, adnexal pathology, or going to be a right hypochondriac tenderness and the pain. All for all, ultrasound will be the preferable investigation to do that. Any surgical procedure, when they ask you in pregnancy, the best time to do is the second trimester. Understand this, second trimester. Very, very important. Okay, I'm giving you additional question could be asked along with that. Okay. Now, what is the izzatplasty used for? That already we have discussed. It is about the scar revision and contracture release. Okay, clear. Now, Honda sign. This is a classical repeat question in an entrance exam, and the Honda sign is seen classically in sacral insufficiency and the fracture. Okay, and it's a standard repeat question. There's nothing to discuss here. And now, investigation of choice for ureteric calculus. Very, very, very important question, because this is a standard entrance exam question often asked year after year. Now, you should understand that if there is a calculus in the kidney, you can diagnose with an ultrasound. If there is a calculus at the VUJ junction, then again you can choose with an ultrasound. If there is a calculus in the bladder, again an ultrasound can be used. Understand this. But if there is a calculus, yes, anywhere in the ureter, could be the upper third, middle third or the lower third, where ultrasound cannot detect, the best will be the option given here, non-contrast CT, and especially will be more specific in the next exam. They ask you it's a spiral CT. Spiral CT. Okay, because contrast you should differ, because it's a renal disease, could be some obstructive pathology, urea creatinine could be having increased, so it's better to give a non-contrast CT. So the investigation of choice for acute ureteric colic, yes, here ureteric colic or acute ureteric colic, it's going to be a non-contrast CT KUB. And ureteroscopy is a treatment. Ureteroscopy can be given as a treatment. If the stone is confirmed in the ureter, then you can put an ureteroscopy and remove it. You can use even Darmia basket to pull it and remove it. Understood? And contrast, of course, I have told you the risk of giving a contrast in renal pathology. Now here you can see beautifully a renal calculus. Yes, yes. Now 17-year-old boy with pain and swelling in the leg, radiologic investigation revealed a sunburst appearance and Codman's triangle. This is a key one. Codman's triangle, automatically it will go for what? Osteosarcoma. Now, best investigation for parathyroid tumor. Okay, the right answer will be system scan. Now, of all the 4 parathyroid glands, understand that of all the 4 parathyroid glands, yes, the pathology is most commonly seen in the inferior parathyroid. Inferior parathyroid gland. Understood? And the most common pathology is parathyroid adenoma. And the best investigation is system scan. System can identify parathyroid adenoma, not the hyperplasia. So, it's very, very clear. So, and parathyroid adenoma is one of the most common cause of primary hyperparathyroidism. Hyperparathyroidism. And the treatment of choice is solitary parathyroidectomy. Understand this. Solitary parathyroidectomy. Okay, is it clear? Yes. So, here you can see the uptake of the thyroid and uptake of thyroid gets washed away, then you see the parathyroid. Understood? Late washout phase of the scan. Okay, thyroid tissue can also take up, parathyroid can also take up, and after some point of time, the thyroid tissue, it will get washed away, and rest of the technetium-99 molybdenum, the tracer, will get localized into the parathyroid adenoma. Understood? It looks like a hot nodule. Complications for diarrhea for 8 months, suspecting a colitis. CT scan shows ahostral, that means a smooth colon. No hostration, smooth colon. What is the diagnosis? Understand, this is called pipe stem appearance. Pipe stem appearance. So, this smooth-walled, okay, and a smooth-walled colon you see in ulcerative colitis, and it will lead to toxic megacolon. Toxic megacolon. And the cause of spontaneous rupture of a toxic megacolon is very high. Okay, the Crohn's disease affects transmural inflammation. Ulcerative colitis involves mucosal inflammation, and ulcerative colitis has classical pinpoint bleeding, ulcers and pseudopolyps, and Crohn's disease has cobblestone appearance and skip lesions. And yet another question they can target you in entrance exam is non-caseating granuloma, classical HPE. They'll ask you this, non-caseating granuloma. The next exam, you can expect this. Non-caseating granuloma, ulcerative colitis, classical HPE will be crypt abscess. Crypt abscess is nothing but neutrophils. They can ask you in pathology. What is in crypt abscess? Neutrophils in the interstitial crypts of Leberkain. And non-caseating granuloma is nothing but macrophage. What is the cell? Macrophage. Understand? Yes. Great. Let's move on to the next. Which scoring system is used for the diagnosis of appendicitis? The easiest question. The answer is Alvarado score. The Alvarado score is totally 10 in number, like a migrated right iliac fossa pain 1, nausea or vomiting 1, anorexia 1, signs of tenderness in the right iliac fossa 2, rebound tenderness 1, elevated temperature 1, laboratory findings of leukocytosis 2, and shift to the left shift of neutrophils is 1, totally 10. 5 to 6 is compatible with the diagnosis. A score of 5 or 6 is compatible with the diagnosis of acute appendicitis. A score of 7 or 8 indicates probably an appendicitis. A score of 9 or 10 indicates very probable acute diagnosis. Acute appendicitis. So, a score of 9 or 10, very important. So, 7 or 8 is probable. A score of 9 or 10 indicates very probable acute appendicitis. Is it clear? So, acute appendicitis, treatment of choice today for acute appendicitis is laparoscopic appendicectomy. Okay. Laparoscopic appendicectomy. Understand this. A patient with an RTA is unconscious, has absent breath sounds in the right side, and the SpO2 is 85%. What is the next step in management? What are we dealing with? We are dealing with tension pneumothorax. Tension pneumothorax. With tension pneumothorax, first is to decompress. The best way to decompress is to put a needle, a wide bore needle in the second intercostal space towards the apex of the lung to let out the air inside, so that the patient becomes little better. Then what you need to do is, you need to do a chest tube insertion in the triangle of safety. They'll ask you, triangle of safety. Okay? Triangle of safety. Understand? And this is the second intercostal space. Okay. So, wide bore needle in the second intercostal space, and triangle of safety is formed by the anterior border by pectoralis major, posterior border by latissimus dorsi, and inferiorly by the fifth rib. And then in the mid axillary line, then you put in through the superior border of the rib into the triangle of safety. Okay, with the underwater seal with 2 centimeters of water under that. Is it clear? Yes. Let's move on. So, tension pneumothorax is a surgical emergency. A patient with a septic shock with a BP of 90/60 millimeter of mercury, what is the drug of choice? The drug of choice is noradrenaline. Where do we go? Where do we go is this. The first drug is norepinephrine. The first drug, first line. And with or without, you can use vasopressin. So, plus or minus, you can give vasopressin. Then the second line of drug is epinephrine. See that? Epinephrine. Okay. And the third line of drug is the dopamine. Okay. So, this is a critical care. This is a critical care medicine. And with surgery, both are almost together. We will not be able to separate which is what. And the fourth line is the phenylephrine. So, the fourth line is phenylephrine. I'll repeat this. The first line is norepinephrine. The second line is epinephrine. Third is dopamine. And the fourth is phenylephrine. Okay, next question. An Alzheimer's patient is unable to eat food for long time. And what is the appropriate feeding tube? See, try to understand. These patients have to be on long-term tube, long-term and feeding support. And most of the time, if they can take food, the best way is not to put any tube. But here the question is asked, what tube you will put? The best option among available to me, if the question remains the same, there will be the PEG. Because, putting on to the Ryle's tube for a very long time or nasogastric tube for a very long time can induce Ryle's tube induced complications, and also it can cause reflux and aspiration, and all those things are possible in case of those related complications. And it is not that PEG does not have any complication, but compared to that, this will be the ideal for long-term feeding of this patient. Okay. So, and there is it is done under endoscopic guidance and a percutaneous puncture to the anterior wall of the stomach. Then you get in, and with the endoscopic guidance, you will put it this tip of the feeding tube inside the stomach, well inside the stomach, and inflate the retention balloon. And then outside, you will have the kind of a fixation in the anterior abdominal wall, and that could be feeding through that. Okay, this is about PEG. Percutaneous endoscopic gastrostomy. Eye of a tiger sign, again, is a standard repeat question for entrance. There is no benefit of answering this question because everybody would have answered it right. And this is nothing but pantothenate kinase. They induced disease, and this is a standard entrance exam question. The skull of the image, it shows, yes, osteolytic lesion. This osteolytic lesions are nothing but follicular carcinoma of thyroid. So, follicular carcinoma of thyroid is one of the curable cancer of the thyroid, but better prognosis would be papillary, but of course, follicular cell is also very, very important, that the treatment is total thyroidectomy. So, total thyroidectomy will be the treatment of choice, and FNAC cannot diagnose. FNAC cannot diagnose between follicular cell adenoma and a carcinoma. It's better to take a true cut biopsy, the standard entrance exam question, or true cut biopsy or excision biopsy. Excision is the minimal excision is hemithyroidectomy. Hemithyroidectomy, and send for HPE or frozen section to confirm a follicular cell cancer. Here shows multiple pulsatile secondaries. Pulsatile secondaries in the skull. Pulsatile secondary skull is classical of follicular. Yet another tumor can produce pulsatile secondary of the skull, that is called RCC. Renal cell carcinoma can also produce pulsatile secondaries of the skull and the long bones. So, follicular cell cancer is very, very, very important. It's most commonly seen in long-standing MNGs. Understand this, long-standing MNGs, they predominantly spread hematogenous, where papillary spreads predominantly by lymphatic. Clear? Yes. A patient with a TPN develops a hypoglycemia, and what is the most likely diagnosis? This is TPN-induced complication. One of the most important complications is the increased insulin sensitivity. Understand this. Increased insulin sensitivity happens with a long duration of TPN. Longer duration TPN can cause increased sensitivity to insulin because possibility to build up of insulin sensitivity and changes in glucose metabolism. So, the question is very clear and the answer is also very clear. And at another aspect, it can also, sudden stoppage can also cause, but mostly it's an error. This is an error. Sudden stoppage of TPN is an error. When you see as a complication, an error is not a complication. Error and complication are not equivalent. Okay. So, this is a complication. Develops a hypoglycemia. This could be a cause. And answer A and D looks very close. Okay. But my preferable answer could be option A as to the process of the TPN. A patient has a recurrent UTI, persistent back pain and hematuria, shows a large branched renal stone and alkaline urine. A stone formed in alkaline urine, Stone formed in alkaline urine, thyroid calculus. The most common infecting organism is a Proteus. Proteus forms the alkaline urine. Okay, they are radio opaque and they are silent calculus. Okay, and they are silent calculus and they are mostly asymptomatic. And the thyroid calculus, the standard entrance exam question is the calcium, ammonia, magnesium, phosphate calculus. Okay, the large calculus, but totally they are asymptomatic. They are branched calculus. And most of the time, the treatment of choice is a sandwich technique. The sandwich technique is PCNL followed by ESWL. Okay, and again followed by PCNL. So, the larger fragments are fragmented by PCNL and smaller fragments again further fragmented by ESWL, and again remaining fragments are removed by PCNL. Understood? So, this is about to tell you the most common, they will ask you this most common renal calculus is calcium oxalate, and the second most common is thyroid, and the radiolucent calculus, these are radio opaque and thyroid is radio opaque, uric acid is radiolucent, and cystine calculus, they can be, it's a controversy, it can be radio opaque because of its sulfur content, content in the calculus. Understood? And so, this is very, very important, but the most difficult calculus to break, the most difficult calculus to break, okay, by ESWL is cystine calculus, and the treatment of choice straight away goes for PCNL. Understand this, PCNL. Very clear? And the Proteus is one of the most common infecting organism for thyroid calculus. Okay, so very classical entrance exam questions. Thyroid you can see in next exam also. See the picture. An X-ray picture show you a branching calculus, thyroid calculus. Next question. A child with a history of recurrent seizures. Now, a ring enhancing lesion, classical. This is a neurosurgery question. A ring enhancing lesion with seizures is nothing other than neurocysticercosis. Okay. So, very, very clear answer. Okay. Identify the investigation shown. It's very, very classical. It's a pelvis. It's a pelvic bone, and you see a contrast here. And typically, it shows the filling up of the rectum and the anal canal. So, this is nothing but an X-ray difficography. It used to see the entire bowel from small intestine to large intestine to the rectum and anal canal, or it can be used to look into the lower GI study. And lower GI study can be used for multiple reasons. Yes, could be a reason of transitory, or could be abnormality in movements and mobility, and or could be for looking for any pathology. So, it is a classical X-ray difficography. Understood? And let's move on to the next. A 38-year-old male with a history of untreated pulmonary TB presents with dysuria, hematuria, flank pain. What is likely diagnosis? If the question remains the same, then my answer could be a genitourinary tuberculosis. TB can go for renal TB also, a pulmonary TB, and that situation definitely all these symptoms are possible. Dysuria is one of the key symptoms here, and hematuria might occur, may not occur, the flank pain yes occur. Okay. So, there are typical features that are available in the 4 pictures, but for me and for you to tell me that the most earliest, okay, and the earliest one would be, okay, renal papillary necrosis. Renal papillary necrosis, and that sheds into the renal pelvis. So, renal papillary necrosis, and it shed to the pelvis called pelvic stenosis, and pelvic stenosis will cause hydronephrosis, and hydronephrosis gets infected to become pyonephrosis, and pyonephrosis becomes an abscess and renal abscess, and the renal abscess becomes a perinephric abscess because of its extension. And also we need to understand this does not stop only the pelviureteric junction, it also can go to the ureter, and involvement of the ureter causes stricture, multiple stricture in the ureter, cause beaded ureter, and then what happens is it also involves the urinary bladder, and to involve the fibrosis, and the fibrosis of the urinary bladder is called thimble bladder. It's called thimble bladder. Okay. So, the key words are, what are the key words here? Renal papillary necrosis, and could produce involving the calyces is called moth-eaten calyces. Moth-eaten calyces, and papillary pelvic stenosis, hydronephrosis, pyonephrosis, perinephric abscess, okay, renal abscess, perinephric abscess, and also can get this is called putty kidney, and this can eventually get calcified, and calcified to form what is called cement kidney. Cement kidney. Understand? So these are the keywords. Putty kidney, cement kidney, moth-eaten calluses, renal papillary necrosis, and beaded ureter, thimble bladder, and the ureter gets pulled away from the bladder opening where it opens in the vesico-ureteric junction, and it is called golf hole ureteric orifice. Ureteric orifice. So there we go. So about renal TB, whatever might be the names, but the treatment is only one. And if it is amenable for medical treatment, ATT, or else it will be the surgical treatment of choice will be, okay, total nephroureterectomy with the removal of cuff of the bladder. Okay, nephroureterectomy with the removal of the cuff of the bladder. So this will be the surgical treatment. Once you start the ATT, you need to wait for minimum 6 weeks to do the surgical treatment. Understood? Is that clear? So with whatever the question, one more question to go. Whatever question I have, I am discussing. 65-year-old man working on a dye factory for 30 years, presents with the flank pain and hematuria. What is that condition suspected? The answer is transition cell carcinoma of the urinary bladder. Understand this. Aniline dye industry is a cause of urinary bladder cancer. Most of the patients will be elderly, more than 60 years, and classical will be painless terminal hematuria. Painless terminal hematuria. Is it clear? Painless terminal hematuria. Elderly patient, painless terminal hematuria, and history of working in a dye factory. Obviously, urinary bladder cancer, UB cancer, and most common UB cancer is transitional cell carcinoma. Transitional cell carcinoma. The next cancer is squamous cell carcinoma, more commonly seen in smoking individuals, and patient on chronic irritation like stone disease and long-term catheterization. Long-term catheterization. Adenocarcinoma of the bladder is a rare cancer, can be seen in patent urachus. Patent urachus. Okay? Is that okay for all of you? So it's about UB cancer. So there we go. There we go. I think for whatever the question the students have given me, I have done the first part of it, and if I get more questions, I'll discuss and post it on the YouTube. Okay? Once again, I wish you all the best for the upcoming exam. So for the next NEET exam, NEET PG exam on 15th June 2025, you should start preparing for that. And then whatever you have done here is good, fine. If you have not done good, we'll move on to the next exam. That's how we need to move. And at Dopamine, yes, at Dopamine, and we have very good classes for expert faculty members. And if you want to look into the more videos and more classes, kindly log on to Dopamine, and you have beautiful packages and special offers for you, and you can learn. That's called Joy of Medicine. It's called Dopamine, so Joy of Medicine. Okay, I welcome all of you to be a part of Dopamine for great learning experience for great results. Thank you very much. Bye-bye.